For Module 3, Part 2, we'll be looking at dysrhythmias. And this is a significant area of the course because with dysrhythmias you have a situation where some of these are fairly normal, but a lot of these are kind of dangerous, and we want to be able to make the diagnosis of what's going on with a patient. A lot of times, again, dysrhythmias, similar to the AV blocks, will be diagnosed based on a rhythm strip. So that makes it a little easier just to look at rhythm strips. You can see these on 12 leads, but usually rhythm strips are used. We'll primarily be using the course pack. And the outline in the course pack is on page 42. We can follow that outline and look at examples in the course pack and then examples on the PowerPoint presentation too. And then after this section, we'll have, I'll introduce a bunch of practice examples that are also found in the course pack, and then give a review for exam 3. So some preliminary information for dysrhythmias, which again is outlined on page 42 in the course pack, is the term, some terms. Dysrhythmia means defective rhythm. Arrhythmia means absence or disturbance of rhythm. You can actually use the terms interchangeably. Somebody has a dysrhythmia or they have an arrhythmia, either way. And another term that's often used is ectopic beat, or ectopy. And this is a beat that originates away from the SA note, where it should not originate. And so if you hear the term somebody has some ectopy or they have an ectopic beat, that means basically an abnormal beat under the category of dysrhythmia. So just a few terms to be aware of. And the clinical significance can be just something that somebody has. It's normal or benign, not a problem in some cases. And that would be certain things like PACs that we'll be talking about, but I'll say that when we get to that section. It could be a problem, maybe a life-threatening problem in the case of, say, ventricular tachycardia, ventricular fibrillation, very much life-threatening. It needs to be corrected right away, and I'll say more about that when we get to that section. Or you could just have dysrhythmias and you're not sure of the clinical significance. You have to dig into it further and figure out what's going on. So it really kind of varies as far as the significance. But again, some of these are extremely significant, dangerous, and need to be corrected immediately. The etiology or cause, origin of dysrhythmias can be normal, again, may not be known, but can often be linked to things like caffeine, nerves, poor sleep, smoking, stress, or even a lot of times with a slow heart rate. Some of the premature beats can cut in during a slow heart rate. So you have a lot of possibilities for different types of dysrhythmias, a lot of etiologies or causes. And a lot of times if I have a patient that has a dysrhythmia, I'll ask them about their history. Are you consuming a lot of caffeine, or do you feel a lot of stress at this point? Are you smoking more? Things like that. Other things that can cause dysrhythmias are hypokalemia and hypomagnesemia. This is low potassium, low magnesium levels. And if somebody is taking, for example, medications like diuretics, or if they drink a lot of alcohol or caffeine, they can be losing these electrolytes, potassium and magnesium, and be having dysrhythmias as a result. Another situation is ischemia, is where if you somebody that has lack of oxygen to the heart. Another possible cause or etiology of ischemia, of dysrhythmias, is ischemia or other forms of heart disease. And this is usually the worst situation, where if you have lack of oxygen to the heart, or if you have different forms of heart disease and your patient has dysrhythmias, then that's a situation where you really want to be concerned and generally try to correct the underlying cause of that. So if they have ischemia or, say, like valve disease, you want to look into the cause of that. If you go forward to the next slide, we'll begin our outline on page 42, and we'll look at some of the initial dysrhythmias. The first one is called normal sinus rhythm, or NSR, and this is actually leading off in this category, but this is a normal. It's not even really a dysrhythmia. It's just a normal form of heart beating, and It just kind of begins the section. So normal sinus rhythm is where you have initiation of the beat at the SA node, and so therefore you have a P wave. There's a regular P to P interval. The rate is 60 to 100, including 60 and including 100. And page 43 at the top shows a couple of examples in the next slide also, where you have just a normal P wave with every QRS, a normal QRS complex, and everything is beating along as it should, and you have a rate that's 60 to 100, including those numbers. If you look at the next slide, same situation. The heart rate here is about, let's see, 300, 150, 100, 75, roughly around 75, so it's easily within the 60 to 100 range. And there's a P wave with every QRS complex, and everything is beating along normally with normal sinus rhythm. There is one form of normal sinus rhythm that is also normal, and this is listed at the bottom of the, I went back to the slide with Roman numeral number 1, and this is called sinus arrhythmia. And this is where it's slightly irregular, but it's really just due to the breathing process, breathing mechanism, and it's really generally not a problem, not a clinical problem. So if we go forward now to a couple of slides to sinus bradycardia, number 2 on the outline. This is where you have initiation of the beat again at the SA node, so you have a P wave. The P to P interval is regular, but in this case the rate is less than 60, 59 or less. And you can see on page 43 in the course pack, you have in the third one down, you have a P wave with every QRS complex. It looks normal, just a slow heart rate. So sinus bradycardia. You can also say sinus bradycardia is another way to say it. If you look to the next slide, you have everything is normal. There's just a slow heart rate and less than 60, and that's sinus bradycardia. Okay, the next one is again in the kind of the normal area, but a little fast in this case, sinus tachycardia. And sinus tachycardia is where you have initiation of the heartbeat at the SA node, and so you do have a P wave, regular P to P interval, and the rate is over 100. If you look at page 43 and 44 in the course pack, you have again normal, but just a faster rate on the bottom of 43. If you look at the let's look at the next slide before we look at page 44. Again, it's just everything's normal, but there's just a fast heart rate greater than 100 for that. If you look on page 44 in the course pack, this is a very fast heart rate, and this is one case where sinus tachycardia is normal in a baby. This is a 1-month-old baby, and the heart rate is very fast. In fact, sinus tachycardia is seen very often in babies, children, and also normally during exercise. Whereas sinus bradycardia is often seen in athletes at rest because they just have a slow heart rate. Sinus bradycardia and tachycardia are generally not a problem. They're normal unless sinus bradycardia goes too slow, like real slow to where you're not getting good cardiac output, or if sinus tachycardia goes too fast to where you're not, again, getting good cardiac output. But usual mild forms of sinus bradycardia and sinus tachycardia are generally fairly normal. If we move forward to number 4 in the outline, I want to talk next about premature beats. And there are 3 types of premature beats. And the first type is called a premature atrial contraction, or PAC. And if you look on page 45 in the course pack, you can see that at the top you have a normal beat, and then another normal beat, and then another normal beat where it has B, and then the next beat where the arrow is an early beat, but it looks normal. And that's considered to be a PAC. It's early. There's an atrial focus with a P wave. There's usually a normal QRS complex, and usually concordant. Concordant means the PAC QRS complex usually goes in the same direction as the beats before it and the beats after it. Concordant. You can have, if you look at the course pack on 45. In the middle, there's something called a PAC with aberrancy. That's outside of the scope of this course, but sometimes PACs get conducted kind of funny looking, but usually they're fairly normal looking. So that's kind of an anomaly called an aberrancy. That's not, the PAC with aberrancy is not testable for this course. You can have PACs in the form of bigeminy, trigeminy, and coupling. Bigeminy, and this is shown on the bottom of page 45, is every second beat or every other beat is a PAC. Bigeminy, atrial bigeminy. Trigeminy would be every third beat is a PAC. Coupling means you have two PACs in a row, atrial couplet, two together. And so those are various forms of PACs. If you look on page 46 in the course back, there's with the arrow, there's a normal beat, then the arrow has a normal beat that's early. Everything about it is normal. That's a PAC, upright P wave. That's kind of a good one to look at. PAC at the bottom is the 1, 2, 3, 4, 5, 6, 7th beat over. And in this case where it's circled, the P wave is actually lost in the preceding T wave. It's kind of tall. And sometimes that can happen as the rate goes a little faster. But again, it's just a normal P wave with an early beat. If you look at the next slide, you have at the top a normal beat, normal beat, normal beat. 4th beat over looks normal. P wave looks upright. It's just that it's early, so it's a PAC. PACs are generally not a problem. The word clinically that we use is innocuous. Innocuous means harmless, usually harmless, unless you have a lot of them or they are triggering other problems. But usually a few PACs are generally not a problem. If you look at the next slide, then you have the next category of premature beats, and these are premature junctional contractions, or PJCs. So singular PJC. And again, these are early, but you have you have the beat starting at the junctional focus, like near the AV node. And you'll have an inverted P wave or no P wave. And we'll look at some examples of this and look at there's three different possible junctional foci, or three different types of PJCs. If you look on page 47, at the top, this is kind of a classic normal beat, normal beat, normal beat. 4th beat over is a PJC. You can see that the beat looks fairly normal, but there's an inverted P wave. And if the inverted P wave is before the QRS complex, this is considered to be what's called an upper PJC. If the inverted P wave occurs after the QRS complex, it's what's called a lower PJC. And if it occurs during the QRS complex and you don't see it, that's called a mid PJC. And so there are three different types. Usually the QRS complex is normal. Usually these are concordant, go in the same direction. And again, a good example is at the top of 47, where the 4th beat over is normal looking, concordant, inverted P wave, in this case prior to the QRS, so upper PJC. That's a good clean example of that. Once again, you can have bigeminy, trigeminy, or coupling, meaning every other beat, every third beat, or two in a row. And if you look on the bottom of page 47, you have normal beat, PJC, normal beat, PJC, normal beat, PJC. So you can call that junctional bigeminy. And that's a good example of that. If you look at 48 in the course pack, you have 3 rhythm strips showing some PJCs. And this is where, if you look at the bottom one where I have the arrows, you have a normal beat, normal, 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 and then the, 7th beat over is early, has a P wave before the QRS complex, so that would be an upper PJC, and then there's a normal beat, and then the next one is early and has the P wave. You can see a slight inversion of a P wave where the arrow points, to a what's called a lower PJC. So a couple of different types of PJCs right in one situation there. And those are kind of in the category of PACs, where they're usually not a problem. And, unless you have a lot of them, a few PJCs are generally, again, innocuous. Okay, the next category of premature beats then is premature ventricular contractions, PVCs, or if you have one, PVC. And these are, not always a problem, but they're more likely to be significant compared to PACs or PJCs, especially if ischemia is present. But again, you can have these fairly normally too. And they are early, but the premature beat has a ventricular focus, so there's no P wave. It has a wide QRS complex, usually discordant, meaning it goes often in the opposite direction of the normal QRS complex. You can again have bigeminy, trigeminy coupling, and we'll stop there for now and look at some examples and then come back to that list. If you look at page 49, there's at the top normal beat, normal beat, normal beat, and then PVC. A good example of that, very wide, early, no P wave, and then you go back to normal from there. And then if you have, on the next strip, you have a large number of PVCs, and one thing about these is they're fairly easy to see, and you can see in this case that you have, they look a little different from each other. And you have in one case a ventricular couplet too. And so if they look a little different, they can be called multiform PVCs, or sometimes the word multifocal PVCs is used. If they all look the same, they're called uniform or unifocal PVCs. And then you have the next strip down has a couplet, and then actually 3 in a row, and then another couplet, and then last strip down on that page has ventricular bigeminy. Every other beat is a PVC. And if you look at page 50, they stand out. These are just wide, big beats that stand out, and they're PVCs, and you can see some cases of couplets and so forth, but fairly easy to see. PVCs. PVCs are generally not a huge problem, but if they tend to hit on the T wave, and if you look ahead in the course back to page 60, there's a normal beat, PVC that was missing the T wave, and then a normal beat. Then the next PVC hit right on the T wave, and it came so early it hit on the T wave. In this case, it caused what's called ventricular fibrillation. We'll study that in a few minutes, but that's a real bad rhythm. It could also cause ventricular tachycardia. And this syndrome is called the RNT phenomenon, where the PVC hits right on the T wave and causes a bad dysrhythmia. And that can happen sometimes, and again, page 60 shows an example of that. So that would be, a case where PVCs can sometimes be fairly normal, but if they hit on the T wave, they can be, cause something that's very bad. You want to look for that. If they increase with exercise, that's generally bad too. If they are present with ischemia, that's usually bad too. So PVCs should be watched a little more carefully than PACs or PJCs. If you look on the next slide, then you have a couple of normal beats, and then again a very early, big, wide beat that's easy to see, and that's a good example of a PVC. Again, all three of these areas, PAC, PJC, and PVC, are considered to be early beats. They come earlier than they should, as opposed to the next section where they'll come later. But actually there's one more slide with a ventricular couplet, 2 PVCs in a row on the next slide. And then the slide after that shows this next category of what are called escape beats or rhythms. These can look kind of like PACs, PJCs, or PVCs, but the difference is that with the P, PJC, PAC, PVC, those are early, and these escape beats happen late. So you got one category early and then this category late. If you have, and these are bad in that the assay node has failed, there's a pause, but they're good because at least there's a backup system. I mean, it's not a good situation, but at least you have a backup situation. You can have escape beats, and this is where you have a single beat. And it can be atrial, junctional, or ventricular. And usually there's a pause coming into it. If you look on page 51 in the course pack, you have a pause coming into those 3 beats at the top. The pause is ended with a kind of a normal looking beat with an upright P wave and fairly normal QRS and T wave, and that top one then is an atrial escape beat, a single beat, not more than one. The next one has the pause coming in. There's an inverted P wave with an upright QRS complex, and that inverted P wave means that it's a junctional escape beat. It's only one, again, so it's a beat, and that's, if you're thinking back to a few minutes ago, that's an upper junctional escape beat. And then at the bottom, you have a pause coming in. You have a big wide beat, no P wave, and this is a ventricular escape beat, again, a single beat. And again, this pause is not a good situation, but at least there's something backing it up. And that's on page 51. On page 52, you have escape rhythms. And this means 2 or more beats. Usually it's a continuous rhythm, just continuous beats. And you can have, again, atrial, junctional, and ventricular. And this is where early in the course we talked about the general internal pacing of the heart. And we said mostly it was at the SA node. This would be the case where the SA node has failed and you have a pause, and therefore you got a backup system. And with an atrial escape rhythm, the rate is usually around 75. With a junctional escape rhythm, the rate is usually around 40 to 60, and a ventricular escape rhythm, the rate is usually around 30 to 40. And these are examples of the pause coming in at the top. You have atrial escape rhythm, more than one, upright P wave, kind of a normal rate, and then on the middle one you have a pause coming in. You have P waves that are inverted, the rate's a little slower, so that's a junctional escape rhythm. Then the bottom one has the pause coming in, and you have a very slow, wide rhythm, which is a ventricular escape rhythm. And those are good examples of escape beats and rhythms on pages 51 and 52. Okay, our next category is number 6, and this one is called supraventricular tachycardia, often called just SVT. And there are some other names for it: paroxysmal supraventricular tachycardia, PSVT, or sometimes called paroxysmal atrial tachycardia, PAT. But mainly for the purposes of this course, we'll just consider this dysrhythmia to be referred to as SVT. The origin of SVT is it's a rapid rhythm that occurs in the atria or around the junctional area, but not in the SA node. If you have a rapid rhythm in the SA node, that's sinus tachycardia. That's different. So it's out of the SA node. Not in the, and we've studied sinus tachycardia. Not in the ventricles. That would actually be called ventricular tachycardia. We'll be looking at that in a few minutes. But SVT is something that originates outside of the SA node, but above the ventricles. And the criteria for this is fast. The term tachycardia means fast, rate of 100 to 250. Sometimes you can visualize P waves, but most of the time you cannot. The QRS complex is generally normal, so not wide. And it's interesting that this rhythm it starts fast and comes out fast. It goes in fast and out fast. And if you look at some examples then, if we pull away from the PowerPoint and into page 53, you see at the top you have a couple of normal beats, and then all of a sudden it goes faster, but the complexes look normal, and then goes slower, like that. So that's a good example of SVT. The second one down has normal beats for a while, and then all of a sudden a quick run of SVT, and then it comes out a bit like that. And that's a good example of that too. In fact, that second one down is a great example. Third one down has again, it goes into it fast, and the fourth one down just shows it being fast. But you can see that the QRS complexes generally look normal, and they're just going fast for a period of time. Now, and that's the main information and examples to have on SVT shown on page 53. You can have some exceptions to normal SVT, or sometimes called PAT. And this is SVT or PAT with aberrancy, and SVT or PAT with block. And these are not testable for this course. But, for example, if you look on page 54, sometimes you can have SVT that looks wide, and that's SVT with aberrancy. And sometimes you can have it blocking out, where you have some blocked beats. But again, page 54 is just something to think about for future learning. But again, the main thing you want to look at is page 53, where you have normal complexes that go real fast going in and come out real fast, and they essentially look normal. It's just that they're fast. This may or may not be significant. Usually you want to look at the underlying cause. If you have a situation where you have maybe lifestyle situations, like again a lot of caffeine or stress or not enough sleep, a lot of times when that's corrected, the person will not have SVT anymore. And but if you do find that the underlying cause is more clinical, like heart disease and stuff like that, that should be explored further. So generally a few runs of SVT in a person now and then, generally not a problem in most cases. On page 53 and 54, you saw the classic examples on 53, and then some future learning on page 54. If you look at the next slide, you can see again a fast rhythm and generally normal QRS complexes for SVT. And again, sometimes it's called paroxysmal atrial tachycardia. We'll just basically stick with the term SVT. The next one is called atrial flutter. Atrial flutter is interesting in that you don't have any P waves anymore. You have what are called flutter waves, or sometimes called F waves. And this is where the atria are not contracting, but they're just kind of flapping atria. And you get these flutter waves on the EKG. So if you look at this on page 55, you can see at the top that the baseline is just kind of what is often called a sawtooth baseline. And then you can see other examples of that too. The atrial rate, which is again is the flutter wave or F wave, is very fast, and the F waves have a sawtooth morphology. The ventricular rate is generally a lot slower at about 125 to 180, and this is good because you want a slower ventricular rate. You can also see on here on page 55 that you have examples of 1 to 1, 2 to 1, 3 to 1, 4 to 1, and sometimes more conduction, meaning that, for example, in the top one, you have 4 flutter waves to every QRS complex. So that's a 4 to 1. It almost looks like 3, but if you count the downstrokes, 1, 2, 3, 4, that'll give you the 4 to 1. It often looks at like 1 less than it really is. But that's a 4 to 1 atrial flutter. Usually the 4 to 1s, the 3 to 1s, often the 2 to 1s are fairly stable. It's when you go 1 to 1, like the third strip down, that becomes a bad clinical situation. But atrial flutter is something that, again, is generally a faster atrial rate than a ventricular rate. 300 to 150 is a common situation, therefore it's 2 to 1. And if you see a resting heart rate around 150, you should always consider atrial flutter. Atrial flutter is fairly easy to see as far as the baseline having that sawtooth morphology or flutter waves. And I would be more concerned about just seeing the flutter waves and be less concerned about the exact ratio. Although if you do get the 1-to-1 ratio, you want to be concerned about that. This has the potential to be dangerous. Patients are generally not left in atrial flutter. They want to, the clinician, cardiologist wants to get them right out of it, and they usually use intervention that includes medical intervention, medications, or some type of a mild electrical shock with an AED or defibrillator that gets them out of that. You usually don't want to leave people in atrial flutter. And again, if you look at the next slide, the common diagnosis here is that sawtooth. Visualize the EKG without the QRS complexes, and you see kind of that undulating sawtooth flutter wave morphology. That's for this course, and for general EKG diagnosis, that's the thing that you really want to focus in on, that sawtooth morphology in atrial flutter. Okay, moving forward to the next one. Actually, there's another example of atrial flutter on page 56 in the course back. Again, it has that sawtooth morphology. The next one is atrial fibrillation, number 8 in the outline. And this is where you have a very rapid atrial conduction at a rate of about 400 to 650. And again, these are not called P waves anymore. These are called fibrillatory, or again, F waves. And the atria are not contracting at all. They are just quivering or shaking. And the atrial contraction is non-productive. It's just kind of like a shaking atria. The ventricular rate is inherently slower, but still fairly fast at 160 to 180. So if you look at the, and we'll get back to the medication for this and so forth. If you look at page 57, you see several examples of atrial fibrillation. These examples on 57 show a fibrillatory baseline, which is kind of a scratchy baseline. There's all those examples on there have no P waves, no flutter waves, but it's all kind of a scratchy baseline that is indicative of the quivering or fibrillating atria in a real fast rate. The ventricular rate on those examples is variable. Again, if you don't do anything about it, the rate is around 160 to 180. That's not a good situation. Usually a patient is put on a medication called digitalis, and there are other possibilities too. And the idea of digitalis then is it will slow the ventricular rate. You'll have a slower ventricular rate to the inherent atrial fibrillation. So you can lower the rate down to more of a normal area. If you look at, for example, the third one down on page 57, there's quite a slow ventricular rate, and that's, or the bottom one even, and that's good. That's what you want to do, is slow down the ventricular rate to the quivering atria. Another thing you can see on here is that the QRS complexes are often irregular. They're not beating along like beat regularly, but they can beat and then go a little faster and then have a pause area. And that's kind of a common thing, or the cornerstone in the diagnosis of atrial fibrillation. In this case, the best way to get the rate is we talked about earlier in the course, taking or looking at a 6-second strip of the EKG and then counting the number of beats in that 6-second period and then multiplying by 10 to get the ventricular rate in atrial fibrillation. And if you look at the next slide, the significance is it has the potential to be dangerous, but most patients are actually left in atrial fibrillation. They go day to day, every day in atrial fibrillation, and if you have them as a patient, you'll expect that they'll be in atrial fibrillation. But they keep the ventricular rate slower by, again, giving digitalis or other medications, and they also would be on an anticoagulant like Coumadin or low molecular weight heparin. And the reason for that is the quivering atria can lead to clots, and you want to have that anticoagulant so you don't have clotting in there. So a common situation would be to leave the person in atrial fibrillation every day they're in it, and have them with a digitalis and maybe Coumadin, and slow their rate down, their ventricular rate, and then keep them from clotting, and then just work with them that way, usually not electrically or medically converted. Page 57, again, has a lot of examples of this, and good examples of atrial fibrillation. If you go to the next slide, you can see an example too where the baseline is just kind of scratchy or quivery, and the ventricular rate is generally irregular in atrial fibrillation. The next dysrhythmia is a very important one, number 9 in the outline, called ventricular tachycardia. And often we generally don't take the time, because of the clinical significance, to say ventricular tachycardia. We just say VTAC is the common clinical way to say this. The criteria for this, 3 PVCs or more in a row. So if you have 3 PVCs in a row, you can say that's a short run of VTAC. If you have 4, that's a short run of VTAC. Or you can have continuous sustained ventricular tachycardia where the person's in it all the time. The QRS complexes are fairly easy to see in that they are wide, like PVCs. and the ventricular rate is generally between 140 and 200. It can be faster or slower, but that's kind of the usual range for it. If it's faster, that's generally more significant. This is a very significant dysrhythmia. It's very dangerous, and usually, almost all the time, the person drops their blood pressure to 0 because of poor cardiac output, and they drop to the floor. You help them to the floor, and you should start CPR and then electrically convert them with an AED or defibrillator and set up an IV and give medications. So it's usually not a good situation. If you look at page 58 and 59, you see a lot of examples of VTAC, and on the top of 58 you have somebody going along normally, and then there's a run of VTAC wide. Middle one has that real fast run in the middle, and then some below that shows it, and then page 59, those examples. The good thing about it, there's really nothing good, but a good thing about it is that it's fairly easy to see, but it is a bad dysrhythmia, and if you work clinically, you'll really learn to respect this and treat it, and treat the patient, and work on getting them out of this with initially CPR, which doesn't get them out, but kind of sustains them until you can convert them electrically or give medications to convert them. And if you look at the next slide, this is a 12 lead with VTAC. Generally, we can see VTAC even better just with the rhythm strip, but it can be caught on 12 leads too. So wide, fast rhythm, ventricular tachycardia. Okay, the next one is ventricular fibrillation, and VTAC we said was bad. Ventricular fibrillation is actually worse, in that it is, there is no person in ventricular fibrillation that is anywhere but on the ground and has a blood pressure of 0 over 0 all the time in ventricular fibrillation. Again, we don't take the time to say it, the full name. We usually just say VFib, and the criteria would be rapid and chaotic ventricular fibrillatory waves, where you just have a kind of a shaking of the entire heart, ventricles, no cardiac output. If you look on page 60, this is an example that we saw earlier, where we had, well, at the top is an example of VFib, but then the one toward the bottom, middle bottom, was a live example where you had the RNT phenomenon. The person went right into VFib. We stopped the treadmill. We started CPR. I was right there for this, and we, got help coming in and started to work with that person who was on the ground and had a blood pressure of 0 over 0. And so you can see a couple of examples there. Pretty easy to see, but again, very dangerous. You want to intervene immediately with CPR and electrical defibrillation and medications. Call for help, get things going. Personally, I had clinical experience doing CPR on several patients in VFib, and I was in position to and did electrically defibrillate 5 patients in my career, and got them with defibrillator paddles out of ventricular fibrillation, usually not on the first shock, but oftentimes in my experience with this, it was on the second shock with the paddles. You got to put gel in the paddles and shock the person that way and bring them out of it. We looked at the example on page 60, and that's a good example of that. If you look at the next one on the next slide, you'll see another example of ventricular fibrillation, and these are you can look at, for example, the difference between coarse and fine VFib. If you have a lot of activity, that's coarse VFib, and you're in all these examples we've looked at so far, coarse VFib, where you got a good chance to get them out of it. But if you have real fine VFib, that means they've been in it for a while, and your likelihood of conversion is a lot less as it gets to be a finer baseline, or less activity, less movement of the heart. One thing about VFib is it should always be differentiated from artifact. And artifact is shown on page 61 in the course pack. And artifact is where you just have a bad connection with an electrode or electrodes or wires, or you have a lot of movement, And if you look closely on 61 in the course pack, you can actually see, initially it might look like V-fib, but then you can actually see R waves in there. And artifact is a rhythm that's just a machine problem or an electrode problem. And if you have a patient that's doing well and talking and walking and they have artifact, you don't want to start some emergency process with them because they're okay. You just want to look at what's causing the artifact, which is their heart is normal, but you have some type of interference problem on that. So keep that in mind, that idea of artifact, and always differentiate artifact from V-fib. Okay, moving forward to asystole. Asystole is considered to be cardiac standstill, and the criteria is a flat line. So there's no activity, the heart is stopped. This is often caused by significant heart problems or problems with a brain situation, maybe an accident, and you have a very dangerous flat line. You can look on page 62 where there's just no activity, just a flat line, and you should intervene immediately with CPR, give medications. You can consider putting a transcutaneous pacemaker into them. Transcutaneous pacing is a way to do this, to try to restart the heart. You have, with VTAC and VFib, you have a pretty good chance of getting the person out of it. With asystole, your chances are not as good, but attempts should be made. And you do not attempt with defibrillation, but you make the attempt with CPR medications and a pacing, external pacing with a person. On page 62, it shows an example, basically a flat line. So if you get that on an exam, you see a flat line, that's asystole. And again, it's considered to be cardiac standstill in a very bad situation. So VFib and asystole, as shown on the slide, are considered to be cardiac arrest. And arrest because there's no productive cardiac output at all. If you look at the next slide, then you have just a flat line again. It can undulate a little bit like that, but there's no activity up and down to speak of, and that's ventricular asystole, or often just called asystole, flat line. So that concludes the material for this Module 3, Part 2. And now I want to get into the next slide, which looks at a lot of practice items, and introduce that slide. We have concluded all of the information for this exam, Exam 3 in this module, but I think in this area, I know from experience in this area, that it's very important to get a lot of practice and see a lot of these dysrhythmias, and then we'll also bring back in the blocks and information like that too. And I'd like to do this practice in a couple of different parts. The first part, we have practice strips, rhythm strips that are on right in the PowerPoint slide coming up in here, and I'd like to go ahead and talk you through those. Feel free to pause and try to do these things on your own, and I'll go through the answers and how we got to the answers and so forth. And then what I would like to do is, and I'll say this again, is that I have a lot of examples in the course pack, starting on page 84. And those examples you can work on your own. And again, you want to look at them, try them, use it as maybe almost like a practice test type of thing. And the answers are provided, but I'll just provide the answers and not take you through every explanation. But you can work with that material. So the first practice area, then, the next few slides have answers on the slide that follows each EKG slide. Again, try these and pause, and we'll go ahead and go through them. The first one is shown, and you can see, and hopefully you've again paused me here, and you can see on the first strip that you have a couple of normal beats, and then you have an early beat that's wide, has no P wave, it's discordant. So that beat, which is the third beat over, and then actually the sixth beat over, those beats are PVCs. And they're in a pattern of every third, so you could call that ventricular trigeminy on that first one. The second one is normal, and in looking at this, I would count the rate as being around, counting down 300, 150, 175, right around the 75 area. There's a P wave with every QRS complex. It's within the normal rate range. So this would be in the category of dysrhythmia, but it's really not necessarily a dysrhythmia, it's just a normal rhythm, and it would be classified as normal sinus rhythm, or NSR, with a rate of 75 for that first slide, those two strips. On the next one, again, if you have tried these, that's a good thing to do, but I'll talk through them. On the next one, you have kind of a scratchy baseline at the top, and this is atrial fibrillation. The one below that has more of a defined baseline, which is, and this is atrial flutter. The distinction between these two is not quite as good as it could be. You'll see on a lot of the practice strips later a better atrial fibrillation, atrial flutter distinction, but this does give the idea of the kind of a baseline that's not very consistent versus a nice flutter baseline. So the first one is atrial fibrillation, second one is atrial flutter. The next one down, there's a normal beat to the far left, and then you have two beats that are wide and early, and these are PVCs, but they couple together, so I would call these, and there's three sets of these, ventricular couplets. So again, for that one you have atrial fibrillation, atrial flutter, and three ventricular couplets. On the next one, you have a situation where things are normal but very slow. The heart rate is 300, 150, 175, 60, 50, well under the normal 60 to 100. But there's a P wave with every QRS complex, and it, other than that, it's normal. So this is what's called sinus bradycardia. Again, you can say sinus bradycardia is another way to say it. On the middle one, second strip down, everything is normal other than one thing. The PR interval is long. There's a long PR interval, and that P wave is conducting these beats, but the PR interval is well over the 5-box limit, and so this is, but there are no drop beats, so this is first degree AV block. And the third one down has P waves that are beating along at their pace, faster than the QRS complex pace. And P waves are, if you look carefully, they are being lost. Look carefully at this, they are being lost in the QRS complexes sometimes. And so lost P waves would be something that would be from third degree or complete AV block. And so this is third degree or complete AV block, and you have again, kind of lost and found P waves, a P wave rate that's faster and regular, and a QRS complex rate that's slower and also regular but slower than the atrial rate. And so third degree AV block. So in summary on those, you have sinus bradycardia, first degree AV block, and third degree AV block. On the next slide, you have a situation at the top where you have P waves, and the first P wave to the far left, there's a drop beat. But if you look over to the next P wave, that conducts a beat with a fairly normal PR interval at about probably 4.5 boxes, 4.5 to 5, so normal. And then the PR interval on the next one conducts the beat. This is the second beat over, QRS complex over, but the PR interval is long, and then the PR interval on the next one is longer, and then there's a P wave with a missing QRS complex, drop beat. And then it resets to a PR interval that's normal, and then longer, and then if you had more, you'd have another drop beat after that. So this is a prolongation of the PR interval with drop beats. So this is second degree AV block type 1, and the other names for that would be Mobitz 1 or Winky-Bach. The middle one has a baseline that has just a fibrillating baseline. It's fairly coarse, but there are no QRS complexes, and this is coarse ventricular fibrillation. or just ventricular fibrillation, this is likely to be a situation that just happened. The person just went right into VFib at this point. The bottom one has a P wave to the far left, and then there's a P wave with the QRS complex, and another one, and another one, and then you have a P wave without a QRS complex, and that's a drop beat. In this case, different from the top one, you have a PR interval that's staying the same, and it's not increasing, but you do have drop beats. So this is second degree AV block type 2, or called MOBITS 2. And this is, so in summary then, on this slide, you have at the top second degree AV block type 1, and then ventricular fibrillation in the middle, coarse VFib, and then the bottom one is second degree AV block type 2. On the next one at the top, you have, this is a good contrast from one that we just looked at. You have a baseline with no QRS complexes, and it's fibrillating, but in this case it's a fine ventricular fibrillation. So ventricular fibrillation that is fine. So this is something that may have happened, a while back, like maybe a few minutes ago. The person went into VFib, say 3 minutes ago. So this is a not as good of a situation as coarse VFib. The next one down, the middle one, has a normal sinus rhythm. Actually, it's a little fast in looking at it closely. Let's see, 300, 150, 100. Yeah, a little bit over 100, so a little bit fast. And the other thing I see here is that there's a kind of a slurring of the QRS complex, which would be a delta wave. And the PR interval is a little bit short too. So I would call this sinus tachycardia with probable WPW because of that slurring initial portion of the QRS complex. And then the bottom one is wide and fast. So this is clearly ventricular tachycardia, or often just called VTAC. This next area of practice is, I think, very important to do, and it's almost like you've learned the material and you're getting some experience at, let's say you're working clinically and you're seeing a lot of different things on a given day or throughout the week, and different examples of things. And this whole area is in the course pack, and it's from page 84 right to the very end of the course pack, 102, page 84 to 102. And on each page you have roughly 5 in that area examples of different EKGs. And these are dysrhythmias and AV blocks and everything kind of mixed in together, and just a lot of examples. And I think it's important to, in this section of the course and for this course in general, just to see a lot of different examples. So the way I would try it is I would use it as a kind of a test, where I would go through and look at all these and come up with an answer, and maybe jot down why that's the situation, and try to then go back and look at the answers that I've provided and compare what you found to what the actual answer is, and maybe you have almost all of them right, and that would be a good thing. And some of these are fairly easy and some are a little bit challenging, and you can go through them again and again, but I would again suggest just looking at it as a kind of a testing situation. And I won't necessarily take you through all of them, but I have provided the answers, and hopefully things will go well with that practice. Next, I want to go forward to a review for Exam 3. Exam 3 is from Module 3, Parts 1 and 2. And Part 1 is conduction defects or disturbances in AV blocks, heart blocks. And Part 2 was on dysrhythmias. And so it's all the material from this module will be testable. There were some areas where I said, future learning, not testable, but it wasn't a whole lot of that. But there were a few small areas of that, and I think I clearly stated or even had written in here that those small areas were not testable. But most of what we talked about and what's in here is testable on this. I'll have 20 multiple choice true-false questions, more multiple choice than true-false. These are 2 points each, so 40 points. These will be things on criteria and, you know, a lot of just the writing on the slides, you know, the different criteria for things like that. And then a lot of questions where you can use critical inquiry to get into skills and EKG recognition. This is worth 60 points, and this will be where you primarily are looking at a lot of rhythm strips, just like the practice sessions, and making a diagnosis of what's on that rhythm strip, and in some cases, you know, thinking in terms of, you know, what's the significance of this. You know, if somebody goes into VFib, for example, we need to, you know, help get them to the floor and start CPR and get some help coming in, and then defibrillate and give medications and things like that. So a lot of rhythm strip recognition, again, out of these areas. And I think with studying of this module and these 2 parts to it, and a lot of practice, you should be able to see, you know, a lot of these rhythm strips and make a diagnosis of what they are.